If you have trouble falling asleep or staying asleep, you could be one of many people, like me, who suffer from insomnia. According to Consumer Reports, about 1/4 of us have chronic insomnia, and up to 2/3 of us struggle with sleep at least one night per week. On this week's Health Talk, a sleep expert will discuss the symptoms, causes, and treatments for insomnia. So stay tuned for an important and informative show that won't put you to sleep. Health Talk is up next. Hi, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about insomnia, a very common sleep disorder. My guest is Dr. Christopher Manfredi, who specializes in pulmonary and critical care medicine at Norwalk. He also is director of our sleep lab. So Chris, knowing you forever, you've been doing sleep medicine forever.
Probably over 22 years, yeah.
Well, firstly, what is insomnia and what's normal? Because everybody must have trouble once in a while.
You know, we don't define it in the way you might think. It's not, how long does it take you to fall asleep? Do you stay asleep? It's really that perception, at least, and the perception that it's causing you problems. And so, what I try and explain to people all the time, a lot of this is how you respond to it. It's actually not normal to just stay asleep for the entire night. And so some of us wake up in the middle of the night, look at the clock, and it's just glad that it's not 6 o'clock yet. Other people who suffer more from insomnia, their perception when they wake up is like, oh no, here I am awake again. And that probably sets up a cascade which makes the problem worse. So it's really a perception of the sensation of sleeping or not sleeping that really is the problem.
Do you have to be tired the next day or chronic fatigue?
Well, you have to really feel like you have symptoms, but it's not uncommon for people who complain of chronic insomnia to actually not complain of sleepiness, which is really paradoxical if you think about how many hours they feel like they slept. So often people will tell me, well, I sleep 2 or 3 hours a night. And I say, well, are you sleepy the next day? No. And the reason why it's no is because there's a very common type of insomnia called paradoxical insomnia, where people are actually sleeping a lot more than they perceive that they are.
Yeah, I've noticed that sometimes where I'll think I've been awake, and yet I'll look at the clock and 3 hours have passed.
Sure.
And I'm not conscious of that.
Yeah, we're not sure why some people perceive of it in that way, and there'll be people who'll be downright angry with me and saying, no, I'm sure I was awake all night, or I only slept 2 hours. And even sometimes we bring those people in the sleep center and we say, and they'll come back after the sleep study and say, see, that was a waste, I was awake all night. And I'm like, no, you were asleep for 6 hours, and they don't believe it.
Chris, let me talk about my insomnia. My insomnia is I have trouble falling asleep. I'll get into bed, I'll feel this pressure to fall asleep. The more pressure I feel to fall asleep, the less likely I am to fall asleep.
Sure.
Now, my wife has almost the reverse. She can fall asleep easily at the beginning of the night, but then she'll wake up at 2 in the morning, and then it's what you described. She can't get back to sleep. Can you talk a little bit about those different kinds of insomnia?
There's definitely an overlap there. Some people have both, some people have one or the other. In people who fall asleep fine but then wake up in the middle of the night, those are the people who I really want to make sure there's not something else going on that's disturbing their sleep. But either way, if you get anxious because you're not falling asleep, or anxious because you woke up and feel like you're not going back to sleep, either way, that's going to make the problem worse. So a lot of people who have insomnia have behavioral things that either started it or they're propagating it, one way or the other. And the most common thing is that the very, very most common thing is that people are spending too much time in bed who have insomnia. They try to, well, I have trouble sleeping, so let me go to bed earlier.
Yeah, that's a really common.
So let me try and get more sleep, but by doing that, you're actually making the problem worse.
So tell me a little bit more about that.
On the other end, in your wife's case, if she feels like she woke up at 3 o'clock in the morning, and if she stays in bed later saying, well, I was up in the middle of the night, so let me sleep a little bit longer, that's spending that too much time in bed is actually disturbing your sleep. It's taking away the pressure to sleep, and also the later we get out of bed, the later you're going to feel tired the next night. So the time you wake up in the morning is what really determines when your bedtime is. So the wake time is very important for people with insomnia.
So So you shouldn't be using the weekends then theoretically to catch up
Absolutely
on your
not.
sleep.
If
Maybe
you're
say-
having insomnia, now people who are not complaining of their sleep, people who are feeling fine, a lot of this advice doesn't apply to them. So if you are working a busy schedule and you're not getting enough sleep during the week and you catch up on the weekends because you didn't get enough sleep just scheduling wise, that's better than nothing. It's better if you would have gotten the sleep all the way through the week. But for people who have insomnia, consistency is very, very important. Consistent time in bed, consistent time out of bed.
It's interesting too, I know the American College of Physicians and other groups have come out pretty strongly that saying that the first treatment for insomnia is behavioral cognitive therapy.
It for sure is.
And maybe you could say a few words, because
Yeah,
I think it's so much easier to take a pill.
Yes, and that's what people come to me. They either want a pill or what I see a lot of, I think the message is getting out to the primary care community that, you know, just giving people a sleep aid is not the correct answer. And there's certainly side effects as people get older. And so I'm starting to see a lot more people in the office who've been on these medications for years, but now their primaries, like if you want to keep taking them, you need to go see the sleep doctor. And in almost most of the cases, 90% of the time, I wind up taking people off of them, not continuing them. And it's literally largely has to do with behavioral. You know, what time do you go to bed? What time do you get out of bed? Are you exercising before bed? Are you drinking too much caffeine? All those kind of things. And cognitive. What is your thought process? Like I mentioned in the very beginning, there's a hugely different process that takes place if I wake up at 3 o'clock in the morning and go, oh great, it's not time to get up yet, versus I wake up at 3 o'clock in the morning and I go, oh no, I'm awake again, I'm not going to sleep. So the cognition of that, the thought process, two people, same exact thing happened, they woke up at 3 o'clock in the morning, two totally different results.
Yeah, and they're self-reinforcing too, aren't they?
Yeah.
Again, for me, and I'm speaking just personally,
Yeah.
if I wake up in the middle of the night, I'm not worried about getting back to sleep, and I seem to get back to sleep really easily.
Correct.
It's that initial sleep that I really struggle with.
Yeah.
And yet, as I said, my wife has a totally opposite experience.
Well, you know, if I was seeing you as a doctor, the thing you would say, well, if you're having trouble falling asleep, maybe you're going to bed too early. Like, so sometimes people are going to bed too early for their circadian clock.
But having been through one of these behavioral courses, an online one, they actually tried to have reset our behavioral clock by getting up earlier, even though we didn't want to get up.
Well, so again, it gets to be very individualized. So for people who have to get up at a certain time for work or school or with these very hard social limitations, yes, then we try and reset your clock. But let's say if you're retired and you don't have such constrictions, maybe as long as it fits your lifestyle, we may go with what's already there. And just clean it up a bit.
So it's not bad if I fall asleep at 2 in the morning and wake up at 10?
No, it's not. If that's where your circadian clock is and it doesn't disrupt your lifestyle, there's nothing wrong with that. I know for a fact when I'm retired, I'm going to probably wind up going to bed at 1 o'clock in the morning. Like,
and let me ask, you know, there's also the early to bed, early to rise makes a man unwise.
Yeah.
And I guess I've seen other data that people who are wake up early are more productive than those who are night. But there's clearly, maybe you could say something, the nighttime people
I don't
versus
know
the
that
morning
there's
people.
hard and scientific evidence that that's true, other than, you know, if you look at it historically, you know, if people get up earlier, it's usually because they have stuff to do, and those might just be more productive. You know, that's like saying people who get up earlier are more likely to have a job. Well, of course they are, because that's why they're getting up early, you know.
Yeah, so
Yeah, so I don't know how much that's true. I think people who get consistent sleep, you know, tend to be healthier. People who are not getting too much or too little sleep. Generally, people who are getting too much sleep, you know, there's usually something underlying that can be corrected.
Chris, what is the right amount of sleep? You know, you hear some people say, I remember one of my professors back when I was in medical school, used to say he's got along on 3 hours of sleep a night. And yet I read that most people need 7 or 8. What's the right amount of sleep?
The right amount of sleep is age-related, and so for an adult, an average adult, it's probably in the 7.5, 8-hour range. And that's just based on, if you look at studies where people are put in conditions where they don't know what time of day or night it is, and you just let them sort of free run, they sleep about 7.5, 8 hours normally. But there's a range there. Some people need 8.5, and it could be normal. Some people can even need more than that, and it can be normal. There are people on the lower end, 7, that kind of thing. Most of the people who you talk, and I see these people all the time, I get 5.5 hours sleep and I'm fine. Most of those people are not fine. Most of those people have just done that for so long they feel normal for them, and that if they were given the opportunity to sleep more, they actually perform better.
Is there? Just going to say, is there a downside of acclimatizing yourself to?
Yeah, your performance is suboptimal, and then there's the question of whether there's a health risk associated with having chronically insufficient sleep. One of the things that's been shown over and over again is chronically insufficient sleep leads to weight gain.
Mm-hmm. Yeah, that seems to be a tie that's increasingly recognized, isn't it?
Yeah, that's been shown across several different studies. So that may be here to stay. When you know how it is. When you see one study that's interesting, but then when other researchers show the same thing, it starts to be probably factual.
Have they shown that the converse, that if you can correct your sleep habits, that it's easier to lose weight, or that people lose weight?
So to some degree, yes. On the flip side, people who have weight gain from sleep apnea, when they go on Cpap, that doesn't seem to cause them to lose weight.
Mm-hmm. So we only got a couple minutes left, but just for the average person at home who's watching the show, let's start off with they're people like me. Several nights a week they have trouble going to sleep. It's not overwhelmingly interrupting their life, but
my best advice
what should they do?
Yeah, my best advice is to stop making sleep an issue. Don't think about it. Like don't overly obsess on it. People come to me, the people who have Fitbits and all this data, the more data is worse. So the people who have all that ton of data around their sleep are the people who probably shouldn't have it at all, because all it does is set up more thought process, and that's going to impair your sleep.
Yeah, for some people say cover your alarm clock so you don't look at the time in the middle of the night.
Think about it. I say, listen, you don't worry if you're going to be hungry at lunchtime. Don't worry if you're going to be sleepy at sleep time. Like if you start obsessing about these things, that's when you start interfering with your drive to sleep.
And other suggestions. How about, okay, you got to get up, go to work by 8 o'clock in the morning, and you want to try to get that 7-hour sleep, so you want to try to get to sleep 11 or 12 at night. Do you have any suggestions? How do you approach that?
Well, I mean, I think, you don't want to overthink it, but by the same token, you want to try and, have some kind of routine where you wind down. It's very difficult if you're going from, there's times where I'm on call for the weekend, like I'm going to call this current weekend, and I might get home at 10 or 11 o'clock at night and eat dinner, and even though I got to get up early for work, it would be impossible to get, I know for a fact, if I climbed into bed at that time, I would not fall asleep. And if you did that enough times where you put yourself in a position to not be able to sleep, then that's where the anxiety comes in, and then it becomes a self-fulfilling prophecy. So you really just want to have a little wind down, try not to do anything in bed other than trying to go to sleep, watch TV outside the room, read outside the room, don't worry about it so much. It's a naturally occurring process, and you will get enough sleep if you give your body the right environment. And if you're still having trouble, you want to see your doctor or a sleep doctor to make sure that there's not something underlying it, like sleep apnea.
There's so many more questions I want to ask you, but we've run out of time, Chris, so thank you very much. I want to thank my guest today, Dr. Christopher Manfredi, for joining me on Health Talk today. And please share your questions and comments by email with us at healthtalk@newvancehealth.org. We'll see you next time, and have a good night's sleep.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. I'm coming back. Ask your doctor, check your blood pressure.
Sleep apnea, or interrupted breathing during sleep, is one of the most prevalent sleep disorders. It's also a potentially serious condition. Not only is the resultant daytime fatigue potentially dangerous, but also chronic sleep apnea can have a long-term effect on your circulatory system and your heart. On this week's Health Talk, we're going to discuss the causes, symptoms, and treatments available for sleep apnea. So stay tuned for an informative show. Health Talk is up next. Hello, I'm Dr. Eric Mazur. Welcome to this week's Health Talk. Today we're going to talk about sleep apnea. My guest is Dr. Christopher Manfredi, who specializes in sleep disorders and pulmonary critical care medicine at Norwalk Hospital. Also a very good friend. Chris, it's great to have you back on the show.
Always a pleasure.
Thank
you.
It's fun because not only are you a great guest, but it's always such an interesting topic. We all sleep.
We all have to sleep.
I think everybody has had insomnia at one point in their life.
Sure.
We're going to, I guess, focus in on sleep apnea. How common is it? What is it? Tell us a little bit more about it.
Well, sleep apnea is very common. Really conservative estimates would put it at somewhere between 5 and 8% of the population, which is similar to diabetes and hypertension. Just getting back to you mentioning insomnia, and it may be a cause of insomnia for a lot of people. But it's a very common illness. It gets more common from age 40 up to age 65. And like a lot of illnesses, it's more common in men, but as women age, they sort of catch up with us.
They lose their estrogens and they...
Presumably, but
they pick up all our bad habits.
One way or the other, they catch up. Yeah.
So what is sleep apnea?
Sleep apnea is a condition where people are having insufficient breathing during sleep. It may be completely stopping breathing, the word apnea, or it can be a decrease in breathing that's enough to make your oxygen level drop or your carbon dioxide level to go up. And there's even a more subtle form where you're just having increased effort to breathe that's waking your brain up out of sleep.
And I know there's a relationship between sleep apnea and snoring. You want to describe that? Yeah,
so snoring is really a sound, and it's a sound that the airflow is not as smooth as it should be, sort of turbulent airflow. Not everyone who snores has obstructive sleep apnea, but most people with obstructive sleep apnea do snore. There's something called central sleep apnea, which is a whole different topic, and people don't snore with that, or not necessarily snore with that.
Stopping breathing sounds very frightening. What happens?
Well, what happens
Tell us
is
about what happens.
What happens is the airway, in most people with sleep apnea, their airway starts off more narrow than the average person. And whether that's because they're born that way or because it's developed that way, usually because of extra weight, fatty tissue encroaching on the airway. They start off with a narrow airway. When they're awake, the brain's keeping the airway open. When they fall asleep, the brain goes to sleep and doesn't protect the airway anymore. And gravity, especially laying down, has a role in that. And as you're trying to breathe, the airway's collapsing. Your brain has a lot of safety mechanisms to make sure you breathe, as you might imagine. And so the brain senses that the airway's collapsing, or it senses that the oxygen's dropping, or it senses that the carbon dioxide's going up. All those signals send up to the brain. Brain opens up the airway. Your brain is awake because of that. Brain falls back asleep. Airway collapses down again, and goes on and on.
So this can happen dozens to hundreds
Yeah,
of
I mean,
times a
on
night.
a, let's say if you had a moderate run-of-the-mill amount of sleep apnea, that might happen 20 times an hour.
Wow. And tell us what's bad about that.
Well, there's
So what?
Yeah, so there's the obvious thing where, you know, if you're not breathing, your oxygen level is going to drop. And in certain circumstances, you know, that could be very dangerous, especially if you mix sleep apnea with sleeping pills or heavy alcohol use or prescription or even non-prescription narcotics. So that could become acutely dangerous. Over time, constantly not breathing, constantly having the oxygen level drop puts a strain on your heart. It can raise your blood pressure, increase your risk of stroke, makes you tired during the daytime because your brain keeps waking up at nighttime. There's an increased risk of car accidents, and there's an increased risk of weight gain, just to name a few things.
So who do we suspect of having sleep apnea? What should they do?
Well, you know, I think in broad strokes, if you snore and feel sleepy during the daytime, despite getting an adequate amount of sleep, there's a high suspicion for me that you have sleep apnea right there. It can affect women, so just because you're a woman doesn't mean you don't have it. I think from my point, I think we all get the middle-aged man that's snoring and overweight. I think that those people aren't falling through the cracks, but I want people to realize that you could be a thin 30-year-old female and have sleep apnea.
Yeah, so it doesn't have to be the thick neck and the fat.
It doesn't have to be.
Just be the anatomy of your
Just
neck
be
or
the
the muscles.
anatomy of the upper airway, yeah.
And the treatment's pretty simple, isn't it?
Well, there's several options. So the Cpap being the one that I think most people have heard of and seen, which is, it's like I mentioned, the airway's collapsing down. So the Cpap is a mask that you wear over your nose, and it's connected to a unit at the bedside, and that supplies enough air pressure, enough support of your breathing to keep that airway from collapsing down. If it doesn't collapse down, your brain doesn't wake up out of sleep, your oxygen level doesn't drop. So that's the most effective treatment, but there's other things like oral appliances and certain types of surgeries, although much less effective than Cpap.
And how, tell folks at home how you make the diagnosis.
Well, we do a sleep study, either a home-based one or an in-lab study. Most people get a home study and mostly based on insurance requirements, but they get a home study. If the home study shows you have sleep apnea, we have the diagnosis, and it's a little oxygen tubing in your nose, belt around your chest, oximeter on your finger, sleep with it overnight, records, then we take a look at it, see if there's decreases or stopping of breathing and decreases in the oxygen levels, and we make the diagnosis.
Yeah, no, this really hits home for my family. I lost a relative, a very close relative, a woman who didn't know she had sleep apnea, who had post-operative narcotics.
Yep.
And she, one morning, the morning after she was home,
right,
and she didn't wake up. And the presumption was, I mean, she took a lot of narcotics for her pain,
right,
but it was not enough to kill her. And
well, that is definitely the scenario where people with untreated sleep apnea have a mortality.
So this is not a trivial issue. I guess that's the point I'm trying to make for people to bring it home. But
it could be dangerous. As a matter of fact, for certain elective surgeries, people get sent to us because there's a higher risk of complications post-operatively if we don't know about the sleep apnea.
Yeah. So Chris, should everybody who is going to surgery be assessed for sleep apnea?
Well, I think everyone who's going for surgery in some way is assessed for sleep apnea. I'm sure their doctor, when they do their pre-op, may assess them for that, but certainly the anesthesiologists these days are really assessing, especially when they want to know about severe sleep apnea, because if you have some mild sleep apnea and you have surgery, I think the risk of complications is pretty low.
But yeah, they said it's the perfect storm post-operative. You've got the drugs from surgery on board.
Got the drugs from surgery on board. Your airways already has a tendency to collapse. We're very sensitive to not having people in pain. So then you take extra pain medications, and it's a perfect storm for a more prolonged airway collapse. But also, as I had mentioned earlier, your brain is your safety mechanism that senses this collapse and wakes up to open the airway. But if the brain has been knocked out with narcotics, you've sort of handcuffed your safety mechanism.
Yeah, that's sort of a scary thing.
Yeah.
And yet, with the prevalence of sleep apnea, I've heard you say that maybe we're overdiagnosing sleep apnea in this day and
Well,
age.
I think,
Not in the sense that,
yeah, no, I think a better way I should have said it is that I think we need to do a better job of risk stratifying. So if we find someone with sleep apnea, like, is everybody with sleep apnea at the same risk for cardiovascular complications? You know, is there a subset of people who don't actually need treatment? And the answer is probably. There's probably a group of people that come to see me who don't have any cardiovascular disease, don't feel sleepy, just snore, whoever's complaining. They do have some sleep apnea on a sleep test. Maybe they don't need treatment. I mean, that remains to be seen.
so for the patient standpoint, we talked about the partner complaining of very loud snoring, maybe even hearing the patient stop breathing and then sort of grumble back to life. But how about the patient themselves? What does a sleep apnea patient feel? What should, I be thinking about?
You know, the majority of people I see who wind up ultimately having sleep apnea, I would say most of them think they don't have sleep apnea. So most of them don't have symptoms or don't readily recognize their symptoms. And most people do not wake up gasping and choking.
That's what I was asking.
Yeah, so they come to me and say, no, I don't have sleep apnea. I never wake up gasping or choking. That doesn't mean anything. By the time you're waking up and gasping and choking, you're at the very tip of that pyramid. So really, if someone says you snore, whether you believe it or not, because a lot of people don't believe it, and you have feeling tired during the daytime, or you have interrupted sleep, or you have a history of cardiovascular disease, high blood pressure, that should warrant at least a screening for sleep.
And I was going to ask the question kind of in a reverse way. We've said that sleep apnea can cause high blood pressure, cardiac disease, cardiac failure, et cetera. Should patients...
Or strokes. Strokes is actually a big
Stroke,
signal.
diabetes,
Yeah,
you
yeah.
mentioned, I think.
Yeah.
Should people with these diseases, onset in midlife, should they be evaluated for sleep apnea? I mean, should
Well,
we
I think-
be thinking the other way around?
I think to some degree, like there's data, especially for hypertension. You know, if you are a man and you're requiring more than 2 medications to control your blood pressure, just that fact alone, there's an 85% chance that you have
Really?
sleep apnea.
And does the blood pressure become easier to control once the sleep apnea is treated?
The blood pressure statistically does go down. How much in a given person, you know, it varies, but in a statistical way, it does go down. It may not get you off your medications, but it definitely seems to have a mitigating effect on the blood pressure.
We've got less than 2 minutes left, but I think a lot of people may be nervous about what the sleep study is. Maybe you could start with that, and then we'll talk a little bit about what the treatments.
Well, sleep study, like I mentioned earlier, most people are going to have a home test. It's a belt around their chest, thing on their finger, oxygen tubing.
Does somebody come into the house and set them
No,
up?
they come to the sleep center. We hand it to them, show them how to use it. They take it home, bring it back to us the next day.
So there's a recording on it that,
It records inside there those 3 pieces of information.
and then somebody goes through that, and
Then I go through it, you know, or whoever ordered it, and we see if there's sleep apnea there.
and you're looking for what are you looking for?
We're looking for decreases in the breathing and associated with drops in their oxygen level measured on that oximeter on their finger.
Uh-huh. And then in terms of the treatment, I guess, and I'll speak for myself here, the thought of having, you know, cased in a mask with a loud machine and things like that, I worry about sleeping.
Yeah, so most people have that same reaction. However, the machine, when working properly, is 100% more quiet than the snorer that's wearing it. So bed partners almost never complain about the Cpap. As a matter of fact, if they do complain about the Cpap, I know right off the bat something's wrong. You don't have it on right, it's not fitted right. And most people, although conceptually you would think you would have worse sleep, you're constantly waking up because you're not breathing. So once you get over the mental concept of wearing the Cpap, most of, especially our chronic Cpap users, they can't sleep without it.
And how long does it take to really acclimatize to that?
Some people get used to it, you know, a day or two, and some people I need to tweak it over the course of weeks or months even.
Huh.
And sometimes it's just one little small change and like, okay, yeah, now I could use it, that's great, you know.
Well, that's all good news and important news, and it's such a common problem. You said it affects such a large proportion
Yeah.
of people. I think we all should be more aware of that, and probably get more people checked for it than already are, although I know people are certainly more aware of it than they were 20 years ago.
Sure.
Unfortunately, Chris, we run out of time, and we could talk about this stuff all day. I really want to thank my guest, Dr. Christopher Manfredi, for joining me on Health Talk today. Please share your questions and comments with us at healthtalk@newvancehealth.org. We'll see you next time.